Next is a debate on whether recent randomized controlled trials have changed my practice. The moderator will be Dr. Stephen Skoog. He is a professor and chief of pediatric urological surgery at the Oregon Health and Science University in Portland, Oregon. Dr. Skoog will introduce his panel members and debaters.
Thank you, Dr. Zagoni, Dr. Stringer, and we'd like to thank the program committee for the opportunity to discuss with you today the recent randomized controlled trials dealing with the use of prophylactic antibiotics in children with vesicoureteral reflux. The randomized controlled trial has been the gold standard for clinical trials. Its methodology allows for elimination of selection bias and confounding, facilitates blinding, and permits the use of probability theory to decrease treatment effect due to chance alone. It has its own problems. Its results may not be generalizable to the entire patient population, and its treatment may be statistically significant but not clinically important. This is a list of the 8 trials in the literature since 2006, and you can see the variability in treatment response to prophylaxis with recurrent infections in the most recent trial showing that there was in fact more infections in the prophylaxis group. How then are we as clinicians to deal with this with our own patients in our own clinics? Fortunately today, we have 2 experts who are going to dissect this issue and present the data to you in a pro and con fashion. Dr. Cal Damone, Professor of Urology and Pediatrics from Brown University and Director of Pediatric Urology at the Hasbro Children's Hospital, will tell you why he hasn't accepted all the results of these trials. And Dr. Tony Corey, Professor of Urology, University of California, Irvine, and Chief of Pediatric Urology at the Children's Hospital of Orange County, will tell you that they have. During the course of their discussions, I've asked them to address these issues. 8 different trials with different results. How do you reconcile that? What are their limitations? And how do the limitations affect their generalizability to your patients in your clinics? Should prophylaxis be offered to all children with reflux? If not, who should get them? Dr. Corey, or Dr. Cal Damone.
Members and guests, good morning. I'll shorten the story for you. After multiple challenges by Stevie Wonders to a golf match with Tiger Woods finally relents and says, okay, I'll play. Just tell me when. To which Stevie Wonder replies, any night that you want. Now, the point of this, of course, is that Stevie Wonder was trying to level the playing field. If you try to apply the recommendations of most RCTs across a diverse population of patients in your practice, you'll find that the playing field is not level. We all know that there are multiple variables that influence the outcomes and results of children with urinary tract infections and vesicoureteral reflux. And as you'll see, many of these randomized controlled trials do not take these variables into account. As Steve said, between 2006 and 2014, there were 8 randomized controlled trials, which compared, among other things, among other variables, continuous antibiotic prophylaxis to no prophylaxis in children who have vesicoureteral reflux. Now, 4 of these studies concluded that antibiotics are not helpful and in some cases harmful to children with reflux. And the other 4 studies, however, showed that antibiotic prophylaxis reduced the risk of urinary tract infections by a combined 37% reduction overall. At face value, that will certainly leave us scratching our heads. Now, I'll grant that the RCTs are level to a certain extent, and that is the study populations all had refluxers in it. But that's indeed where the similarities end. Because the reason for different recommendations from these RCTs is that the RCTs study different populations. If we look at the RCTs that determine that antibiotic prophylaxis is not protective, with one exception, the study populations had low grades of reflux, bladder bowel dysfunction was not addressed, There was significant variability in the diagnosis and documentation of urinary tract infections. And in certain cases, the populations were extremely selective. For example, let's look at the Guerin study. This is the study that our pediatricians seem to quote the most regarding children with reflux. This study clearly had selection bias toward children with lower grades of reflux, but also children with lower risk for development of urinary tract infections and renal scarring. The exact patients that this study excluded would be the ones that we would be most aggressive about managing, either with antibiotic prophylaxis or surgical correction. Exit criteria, as you can see, included 2 episodes of pyelonephritis, failure to comply with urinary prophylaxis by admission, or loss to follow-up. Clearly selection bias against children who may have a higher risk of renal damage from vesicoureteral reflux. Now, I'd like to interject a warning here. The choice of no antibiotics in the treatment of a child with reflux, especially those who presented with a urinary tract infection, should be considered an active treatment option, not equivalent to everything is fine, call me if you need me. It should consist of education with modification of UTI risk factors such as voiding habits and constipation, targeted follow-up, and assurance of access to care. Now, in the group of randomized controlled trials that determined that prophylaxis was protective, in general, there was a wider range of reflux in the study population, and at least in some cases, bladder bowel dysfunction was addressed. However, if we look at the Swedish study, for instance, which did show that low-dose prophylaxis or endoscopic correction resulted in fewer urinary tract infections, at least in their female population, as well as fewer developed renal scars, it's important to point out that over 60% of their study population had an abnormal DMSA scan on entry. Clearly a bias towards children who might have a higher risk from urinary tract infections and vesicoureteral reflux. Let's have a look at the 2 of the best designed randomized controlled trials, at least in my opinion, representing over 1,100 children with vesicoureteral reflux, the PREVENT study and the RIVER study. Both concluded that urinary tract infection risk was reduced with antibiotic prophylaxis. And while the inclusion criteria were broad, these studies also were biased towards children who had lower grades of reflux and predominantly female patients, which is reflective of the general population of refluxes that we see in our day-to-day practice, of course. So it's clearly understood. But then again, how do you apply these recommendations to that young infant male with high-grade reflux? Well, the answer, of course, is that you should not. In fact, interpretation of randomized controlled trials should take into account other factors as well. And this was nicely pointed out in a recent publication by Wang and Roth. One must consider the healthy volunteer effect. Enrolling a patient in a randomized controlled trial, maybe particularly a child, automatically provides a different level of surveillance, detection, and monitoring and treatment of children with urinary tract infections. In most all of these studies, patients were recruited after 1 or 2 urinary tract infections, and in many cases, afebrile urinary tract infections, which means their risk of acquired renal damage is very low intrinsically. We all know, of course, that the risk of renal damage increases exponentially as the number of urinary tract infections increase, as well as the grade of reflux increases. And most of these studies, of course, were underpowered to detect the differences in renal scarring. And additionally, although the endpoint is often renal damage, the development of a febrile urinary tract infection in a child has intrinsic morbidity and cost that oftentimes is underrated and swept under the rug. Take-home message. We as surgeons are trained to know the limitations of a particular operation based on anatomical differences. It's the same with randomized controlled trials. We have to understand each limitation that these trials may pose. All right, I know what you're thinking. Get off your high horse. There are no perfect randomized controlled trials. And I agree with you. But here's the problem. we need to recognize that each randomized controlled trial draws its conclusion from its respective study populations, and that we should not extrapolate the results beyond those study populations. And this is where we've gone over the edge a bit. We've used the conclusions of these trials to develop guidelines. Guidelines which our primary practitioners are using on the front lines to manage children with urinary tract infections and reflux. And there have been several guidelines that have been developed over the years. They have very, very different conclusions and recommendations. If we look at the AAP and the NICE guidelines, for instance, the recommendation of these guidelines was that a child who has a febrile urinary tract infection does not need avoiding cystourethrogram after that first infection. Now, these recommendations were based on the presumption that reflux has a limited role in the development of pyelonephritis and renal scarring, and that even if a child has reflux, based on certain RCTs, antibiotic prophylaxis is not necessary anyway. Therefore, why bother looking for it? But it's important to point out that there are likely hidden agendas with each of these efforts. I don't mean to minimize the fact that cost containment, radiation exposure in children, and the trauma of VCUG are insignificant. They are indeed important. But it makes me wonder how important they were and what kind of driving factor they were in arriving at their conclusions. There's a sign that hung in Albert Einstein's office at Princeton. It said, "Not everything that counts can be counted, and not everything that can be counted counts." We all know that there are many variables affecting the outcomes of children with reflux. Any one of these can be a game changer, and every one of them is important, and every one counts. And as we know today that focusing on grade alone of reflux and managing of children with reflux is inadequate today, similarly, to take the recommendations of a randomized controlled trial and broadly apply them over a diverse group of patients with reflux is overly simplistic. So the next time you see this cherub with reflux in your office, your job is to figure out which randomized controlled trial you can apply to individualize his management. That's how to get it right. Thank you.
Good morning, or almost good afternoon. How are we advancing this? There we go. So there's still some lingering questions in reflux. That's a list of questions that in every clinician's mind still linger. What's the benefit of antibiotic prophylaxis? Which antibiotic? Which patients benefit? What's the risk of renal injury for patients with reflux? What's the need for initial and follow-up voiding cystourethograms? And what are the indications for surgical correction? Of these, only the issue of benefit of antibiotic prophylaxis has really been addressed by randomized controlled trials. And I agree with Dr. Calderon, those two studies did not show a benefit for prophylaxis, but you could argue that they were underpowered, there were selection issues, they were non-blinded with no placebo, there was compliance with antibiotic issues, the circumcision status of the males was not identified, and the selection of the antibiotic with the resistance patterns across communities, which varies significantly, and the issue of bladder and bowel dysfunction, which plays an important role in infections, was not accounted for or treated. However, two of the other trials that he mentioned, which as showing no difference, really, if you look carefully, they show the same 50% reduction in benefit in prevention of infection. In the French trial, the same idea, 17% versus 26%. And if you look at which patients benefited most, they'll identify the high-risk patient. So even though these were underpowered trials, they did show a difference in infection rate at 50%, which is the same as the Guerin trial, the PREVENT trial, which everybody quotes, and this has over 500 patients in it, and again, a 50% difference in protection using prophylactic antibiotics. The Swedish study is an important study because they chose to enroll patients that are at higher risk for infections. So they enrolled children that are 1 to 2 years of age with grades 3 and 4 reflux. Clearly, these are children that are at high risk, and they presented with a higher incidence of renal scars at diagnosis. And in that study, girls were at particularly high risk for breakthrough infections and recurrent infections. And the girls that had febrile infections, if you compare the ones on prophylaxis versus the ones that were being surveyed without antibiotics, there was a much, much higher difference than all the other studies. So what are we learning from this? We're learning that in the patients that are at higher risk will have a more benefit from preventative antibiotics than patients that are at lower risk for recurrent infections. The RIVER trial is clearly the largest randomized controlled trial for vascular-enteric reflux. And it was a well-designed trial. And again, it showed that by using prophylactic antibiotics, you reduce the incidence of infections by the same 50%. Another benefit was that these breakthrough infections or these recurrent infections occurred much earlier in the patients that were on placebo versus the patients that were on prophylaxis. However, these were patients that were low risk, as evidenced by their almost no renal scars at presentation, and 92% of them were grades 1 to 3 reflux, 92% enrolled after their first infection, and only 4% with renal scars at presentation. So what important messages have I learned from this low-risk population? And I underscore low risk here, that reflux has limited morbidity in the majority of patients, and that you need to treat 8 patients for 1 patient to benefit. So our job is really, let's find those patients that are at risk. And if I look at the RIVER trial and see what were their effect modifiers, clearly children that had grade 3 and 4 reflux in the RIVER trial had a much higher incidence of infections than the patients with grades 1 and 2 reflux. Patients that presented with febrile initial presentation with a febrile infection, and patients that had bladder and bowel dysfunction. So let's select those patients and be more aggressive with them. And if you contrast this with the Swedish reflux trial, the younger children with higher grades of reflux and the higher incidence of scars at presentation, you see the difference and the benefit that antibiotic makes in that patient population. So, in low-grade reflux, antibiotic prophylaxis does not reduce renal scarring or chronic kidney disease. Antibiotic prophylaxis results in a modest reduction in urinary tract infections. The likelihood of resistant organisms causing infections is higher in the group on CAP. The question that still lingers is, are the results with sulfamethoxazole trimethoprim cross over to other antibiotics? Because that's the antibiotic that was used in the RIVER trial. Dr. Caldemon summarized some of the factors that are responsible for these recurrent infections. And our job is to define who better benefits from prophylaxis. And because clearly the younger child with bilateral high-grade reflux is at a much higher risk than the child with low-grade unilateral reflux. Remember that reflux is a spectrum. It is not a black and white disease. To that end, Dr. Heides, our graduated fellow, did this as a master's research project, where we came up with an app called the iReflux Risk Calculator that you can download freely at the App Store or at the Children's Hospital of Orange County's website. And if you just plug in your patient's criteria, it'll spit out for you a probability of infection that you can use to decide how you want to manage that particular patient. And using that app, we created a categorical risk stratification for patients. So the low-risk patients, which are 67% of your reflux population, the ones with low-grade reflux, without bladder and bowel dysfunction, and the circumcised males, have an infection risk, a breakthrough infection risk of only 8%. So this is a patient population that you can safely observe without the need for prophylactic antibiotics. The intermediate risk group represents 27% of the population and has a 27% chance of infection. And the high-risk group represents only 6% of the population and has a 62% chance of infection. Clearly, this is a group that you may want to consider intervening earlier with correction of their reflux, and the intermediate risk group may be the group that benefits from prophylaxis. But it does change how we think about reflux and how we approach reflux. So my take-home message for you is that reflux is not a black and white disease. It is a spectrum, and you should treat it as such. That antibiotic prophylaxis reduces recurrent urinary tract infection, and that reduction is proportionate to the patient's risk for infection. That other than the morbidity of a recurrent infection, the risk of renal injury in the majority of patients is low. And we need to manage each patient according to their risk profile, i.e. their need for follow-up voiding cystourethograms or their need to be on prophylactic antibiotics. And our job as clinicians is to work hard on modifying the risk factors that we can influence. Thank you very much.
So I think we can say that, safely say that prophylaxis does reduce risk of urinary tract infections in patients with reflux, but we need to know the limitations and the applications of any studies in regards to its use. The prophylaxis decision is a multifactorial decision that involves individual patient risk stratification. I'd also like to thank our two speakers. They went to a lot of work to put this together. And in doing so, I thought I could award them something that would really, truly mean something. So I thought for their magical display today, the Tony Award was perfect. Thank you.
Thank you.